we are at ACC 2016, and as part of the Cardiovascular Clinical Trialists Forum presence here, I'm talking very kindly with Dr. Boer and Dr. Pitt regarding their presentation of the use of subcutaneous furosemide today. So let me start and ask if you could just tell us about what you did and about the results that you found.
Today I presented the results of a study that we recently conducted with a novel formulation of furosemide that is newly formulated so that it can be injected subcutaneously. We enrolled 10 patients with chronic systolic heart failure, and I did a crossover study. So one day a patient would take 80 milligrams of furosemide orally, and 14 days later the patient would be administered 80 milligrams furosemide subcutaneously. And the main results were that it was very well tolerated, and that there were higher furosemide plasma levels with the sub-Q administration. So future studies clearly should be larger, and we should see what it tells us about diuresis and so forth. But this was the first attempt, and actually quite exciting.
So let me just mention that Rudolf said it was reformulated. It had to be changed from the pH of the usual furosemide, which is around 9 to 7, because it would burn, and so that had a complete reformulation. And the other part of this is unique pump delivery system, that it's a 20 milliliter vial and a pump that the patient just puts on, and it self-fills and presses a button, and administered over 5 hours, get 80 milligrams. And so in the end, we think this, as Rudolf showed today, this can mimic what we've achieved in the past with IV, and that obviously opens up lots of applications. Of course, as you know, when people come into the hospital with heart failure, mostly what we're doing is decongesting them with IV diuretics. And so there are several trials planned. One, the Heart Failure Network, the NIH, is considering a trial where they're going to take people who are already in the hospital, and after they're stabilized, will consider randomizing to either go home on the pump or stay. And we at the University of Michigan are planning a pilot trial where people come into the emergency room of the heart failure clinic, and we'll eliminate people with lots of comorbidity, but if they have not a lot of comorbidity, we'll give them a test dose of IV furosemide, and if they respond within an hour or so, they'll be randomized to go home on the pump or to come in. So that has tremendous cost implications. And then there are, of course, many other applications in the future. You think about nursing homes and other situations. So this really could be a game changer.
Absolutely. So one of the things that we saw in what you presented today is that you saw similar outcomes in terms of the outputs of what you were looking at between the groups. Do you want to talk a little bit about the differences you saw and similarities?
Well, in this study, this is a very small study. There were 10 patients, so this was not powered to anything, let alone diuresis. And we also wanted to have some fluid flowing, so to speak. So we also wanted the patients to drink approximately 1.5 liters during the period of the study. So the diuresis outcomes, I think, here are indeed they were comparable between oral and SC, but there was more furosemide in the system of the patients, and I think there's really no doubt that if there's more furosemide systemically available, patients will respond by enhanced diuresis. And what you also observed was quite interesting. People taking oral furosemide, the bioavailability is highly variable. This also, I think, is really comfortable to what we see as clinicians, is that some patients will respond with a vast amount of urine output to a tablet, whereas other ones don't respond barely at all. So there's high variability, and I think you can overcome this by sub-Q.
So the other thing we've learned, and there was a very nice study that came out of the Mayo Clinic from Wayne Miller, where they took people who came into the hospital with acute heart failure, and they measured their volumes with the radioactive technique, and then when they're ready to go home, they didn't have a lot of rows, they looked like they're ready to go home, they remeasured their volumes, and they found even though clinically they looked euvolemic, they were actually hypovolemic at about 80%. So we're sending people home who are hypovolemic and obviously they tip over with just a little bit of added sodium. So this new tool will allow us to extend that use to the home. So we have a lot to learn. We need really good, well-powered, randomized trials, but we've been in conversation with the FDA and we know the path forward, and we think it's a very exciting opportunity, but we have to prove it, and we're just at the beginning.
Fully agree, sir.
Just to take the last step, you spoke about wonderfully about the next trial steps for this, and you mentioned talking with the FDA. For a drug that the formulation is different, but it's been around for a long time, can you tell us a little bit, if you can, about the details of how that regulatory approval process?
So the FDA is not concerned about furosemide. They know about furosemide, so they're more concerned about the pump and the safety and the patient experience, and it's reliable. There's nothing we're going to teach them about furosemide. They've learned that over many, many, many years, so that's not the issue.
What we've seen in those 10 patients that were administered for 5 hours, we took pictures every hour from their skin. We asked them, does it sting, or can you feel at all that maybe your subcutaneous space is being filled up or something? None of that.
So then there'll be other questions about, we give it at home, monitoring people, do we get dehydrate them, do we get hypokalemia, how do we monitor them? These are all things we're going to have to learn and do well and make sure it's safe.
Excellent. Well, thank you so much. This is coming from ACC 2016, and this is through the Cardiovascular Clinical Trialist Forum. Thank you.